The broadcast is now starting. All attendees are in listen-only mode.
Happy New Year, and welcome to our webinar on everything you want to know about melanoma vaccine therapies. Vaccines are commonly thought of something that you give to your children to prevent disease. But actually, there are a few vaccines that do prevent cancer. But tonight, we're going to discuss cancer treatment vaccines that are designed to boost the immune system so it can recognize and attack cancer cells. We welcome back Jedd Wolchok, melanoma expert, vaccine specialist, and terrific oncologist from Memorial Sloan Kettering. His research is focused on the development of innovative ways to use the immune system to treat cancer. And he's here to explain to you further about this exciting field of vaccine therapy. And don't forget to stay tuned after the program for questions and answers. Now here's Jedd.
Okay, thank you, Catherine. It's, again, a pleasure and a great privilege to be able to participate in one of these terrific webinars. I think you gave a really great introduction to the field of vaccine therapy for melanoma, and I've entitled my talk, Vaccines for Melanoma, Where Are We? And so I'm going to give a rather broad overview of what goes on in a melanoma vaccine trial, what kinds of trials have been done, why is it so difficult to immunize against melanoma and other cancers, for example, and where we're going next. So if I could have the next slide, I just want to review that we divide the field of immunotherapy into two general areas. One of them is called active immunotherapy, and the other is called passive immunotherapy. And the active immunotherapy is when we as doctors and patients ask the immune system to go out and do something. And in this case, that doing something is getting rid of cancer. Passive immunotherapy is when we do the work for the immune system by giving, by IV injection, for example, antibodies, such as a treatment for lymphoma called rituximab or Herceptin for breast cancer are both passive immunotherapies. Some of the treatments that are going on now at the NCI and the Moffitt Cancer Center and University of Washington and MD Anderson look at T-cell infusions, and that's also passive immunotherapy. But vaccination is really when we ask the patient's immune system to do something in terms of making its own antibodies or T-cells to fight the cancer. I'll take the next slide. So a general question is, can the immune system recognize cancer? Because if the answer to that question is no, then we can all just go home early and I could have dinner. But the answer is not no. The immune system can recognize cancer, and I think my job and the job of people who do similar research to myself are to figure out how to get the immune system to recognize cancer better. So I'll just take the next slide. And I'd like to recount for you a patient who was treated here at Memorial Sloan Kettering who taught us a lot about how the immune system can see cancer. And this is someone who was treated here by some of my very senior colleagues, actually 35 years ago when this patient was 17 years old. The patient had melanoma from the left chest skin that had spread to lymph nodes in the neck, the supraclavicular area by the collarbone, and also the armpit area. And the patient was treated with surgery, with dacarbazine chemotherapy, and with 2 different kinds of vaccines, a so-called autologous vaccine made from his own tumor, and an allogeneic vaccine, which is somebody else's tumor that is made into a vaccine. He kept recurring, but then actually the melanoma stopped coming back. And now the patient has actually been free of disease for over 35 years. And because of this fairly extraordinary clinical benefit that the patient had, investigators at the Ludwig Institute, that's LICR on this slide, studied very carefully what this young man's T cells or immune cells were seeing on his tumor cells, because they noticed that when they combined this young man's T cells with the tumor cells in a plastic dish, the tumor cells would die. And what they learned was that this young man's tumor cells had several targets that were recognized by his immune system. One of them was called tyrosinase, here shown in red, which is a normal protein found in skin cells and melanoma cells, and it's the enzyme that helps our skin make melanin pigment. And so this was a very important observation because it showed that the immune system could recognize a component of melanoma cells that's part of our normal body, that's in every normal skin cell. Similarly, the immune system could recognize another protein called MART1 or melon A, as well as a mutated protein. And this was also very important because this showed that the immune system could really see one of the mutated or changed proteins that is specific to the melanoma. So this really showed us a lot of important things. Studying individual patients' immune systems carefully is critical to our success. And this patient, again, remained free of recurrent melanoma now for 35 years. And it was really observations like this and other patients that showed us that the immune system is capable of seeing targets on cancer. I'll take the next slide. So with that knowledge in mind, the next thought was, well, let's make a vaccine against cancer, against melanoma, because we know that vaccines are very successful, very important in preventing death from childhood infectious diseases. Just spectacular results time and time again. And now we even have some results showing that vaccines can prevent cancer in terms of cervical cancer and also the hepatitis B vaccine in preventing that virus-related cancer. But those 2 cancers, cervical cancer and hepatitis B, are a little bit different because those are cancers that are known to be caused by viruses, whereas melanoma, that's not the case. So here, with the case of melanoma, the challenge is a little bit different because we're asking the immune system to look at a melanoma cell and say, this is so much different than the normal melanocyte, the normal skin cell that the melanoma came from, that the immune system is going to be eager to respond to it. Because we know that the immune system is not very excited about attacking normal body parts. If that happens, we end up with autoimmune diseases like rheumatoid arthritis or lupus. And one strategy to overcome this reluctance of the immune system to recognize targets found on melanoma that are also found on normal skin cells is to use the target from a different species. And that's where this term xenogeneic immunization comes from, with a gene or a protein from another species to try to fool the immune system into seeing this as something foreign. Okay, I'll take the next slide. And so the goal of vaccination really is to try to convince the immune system that the enemy is ourselves and to respond to targets that may be found on normal melanocytes and to respond against them as if they're dangerous. Okay, I'll take the next slide. So there have been various approaches to vaccination against cancer. And I'm going to go through this slide kind of slowly because I think there have been a lot of clinical trials using a lot of these approaches. And so far, nothing has really worked that well. So I think it's important to understand what all these approaches are and what the advantages and disadvantages are. So the first and easiest to understand vaccination approach are whole melanoma cells. And these can come in two flavors: autologous, meaning the patient's own melanoma cells, or allogeneic, somebody else's melanoma cells that have been grown in the laboratory. And the idea is that, the same way that the first infectious disease vaccines were made from either killed or attenuated viruses and bacteria, if we kill or irradiate melanoma cells in the laboratory, those might be a way to immunize against melanoma. And so there have been some clinical trials using autologous vaccines. Basically, if a person goes to have surgery for melanoma, if they have a big enough lymph node removed, then there have been some companies and some universities that have been grinding up those tumors and mixing them with immunologic substances called adjuvants to make them interesting to the immune system, and then giving them back as a vaccine. And the attractiveness of that approach is that what's in the vaccine is what's on that person's melanoma. So there are no irrelevant targets. Everything that the immune system should need to see is right there in the syringe. The downside to autologous vaccines is the person has to grow a tumor big enough to make the vaccine from, and also it doesn't get by the fact that if the tumor wasn't immunogenic when it was in the person, do we really think that killing it and maybe mixing it with a chemical is all of a sudden going to make it interesting to the immune system? We don't know if that's true. That there may be some things about tumors that are inherently immunosuppressive, and just by grinding it up, we might not be getting past that. Allogeneic melanoma cells are convenient because they don't have to be prepared for every individual patient. They're kind of an off-the-shelf product. Someone else's, melanoma is grown in the laboratory to large numbers. It's then killed or irradiated and then put into vials, and a lot of people can be treated from that. The downside to that is that you may be immunizing someone against targets that are only relevant for the other person that the melanoma came from. You're relying upon the assumption that there are shared targets in that vaccine that will be interesting to the patient's immune system. And there have been products that have gone to phase 3 trials of allogeneic melanoma cells. The most recent one was a product called Canvaxin, which was first developed at the John Wayne Cancer Institute, which looked very good in early clinical trials, but in the end was shown not to be helpful in terms of preventing recurrence after surgery for melanoma. So those are probably the earliest investigated of the vaccine approaches and the easiest to understand. Other approaches have been to purify targets, individual proteins or individual sugar molecules found on melanoma cells, and just immunize with them. Another is to use something called a peptide vaccine. And a peptide is just synthetic protein made in the laboratory. And these have the advantage of being really easy to make. They have the disadvantage of only being small snippets of protein. And so that may not be enough to get the immune system activated enough to recognize, a melanoma cell in many different ways to get it to kill the melanoma cell. And in addition, many of these peptide vaccines can only be used in people of a certain HLA type. And this is something that's talked about a lot. HLA types are like blood types. They are what distinguish one person from another. And they specifically relate to markers on our immune cells that determine what the immune cells can see. And as opposed to blood types where there are only a few, there are a lot of different HLA types, the best known of which is something called HLA-A2, which is very commonly found in people with melanoma. About 40 to 50% of people with melanoma will have this A2 marker on their immune cells. And so we know a lot about what targets bind to A2. But we need to really get past this and develop vaccines that are not so restricted just to A2 and a couple of other tissue types. The next type of vaccine I'd like to talk about is the dendritic cell vaccine. And there's been quite a few trials of dendritic cells. Dendritic cells are special white blood cells which are found all over your body that are uniquely equipped to show things to the immune system. So they are very commonly found, especially in the skin, so that if something happens to your skin, you get bitten by an insect, or you cut yourself, and some dirt or debris gets in there. All these dendritic cells are what latch on to whatever breaks through the skin and show it to the immune system. So they're called antigen-presenting cells, or APCs. And they are very, very powerful ways to show things to the immune system. And so for about the past 10 years, there have been trials of different types of dendritic cells that have been loaded or mixed with peptides or dead melanoma cells to really enhance the ability of the body's immune system to see these targets. And so the dendritic cells are loaded with the target in the laboratory, and then the dendritic cells from each individual patient are injected like a vaccine. And this, again, is a patient-specific product. You're injected with your own dendritic cells that have been made in the laboratory. In some cases, there have been some immune responses seen. There have been some patients who have had tumors that have shrunk a bit, but it is really not yet known how many people will benefit from this kind of thing. But it's really a testament to our ability to bring things from the laboratory to the clinic, that we have been able to make these dendritic cell vaccines for so many people. But again, there's never been a huge trial that has demonstrated, the most important clinical benefit, meaning melanoma, recurrence is delayed or eliminated because of a dendritic cell vaccine. Then there are two recombinant types of vaccines. Recombinant meaning genetically manipulated. The first is recombinant viruses. Now, we know that viruses are really interesting to the immune system. That's why we all feel so cruddy when we get the flu, because that's our immune system responding to the virus. So scientists have sometimes taken viruses like those that cause upper respiratory infections, called adenoviruses, or they've taken other viruses like the ones that cause vaccinia or smallpox, and they've taken the not the actual smallpox virus, because that's too dangerous, but an attenuated one, and they've spliced in genes for proteins that are found on melanoma cells into these viruses, and then infected people with the viruses. So when you get infected with the virus, you may get some symptoms, a little bit of the viral infection, but the virus is actually making a melanoma protein and showing it to the immune system. And so since the immune system is so interested in the virus, it may be very interested in this melanoma protein. And so there have been these recombinant adenovirus vaccines. There have been these vaccinia-type virus vaccines, which are based on the smallpox vaccine. And there have been several others called alpha virus vaccines, which are based around the yellow fever vaccine platform that try to take advantage, again, of how immunogenic viruses are and then plug in a target into that virus that is found on melanoma. Now, our group here, and again, this webinar is not for advertisement, so I'm not going to talk too long about my own research. But just to give you an example, we've been interested in genetic vaccines called DNA vaccines, which are like viral vaccines, but instead of injecting the whole virus, we're just injecting the DNA that tells the body how to make a protein that's found on melanoma cells. Now, you might ask, well, if it's a protein that's found on melanoma cells, and if melanoma cells look so different, look so similar to normal skin cells, why would just injecting a gene for something that's found on normal skin cells under the skin cause the immune system to respond? And that's where we get back to that word I used before called xenogeneic vaccines. And we'll take the next slide. Right. And so it was this whole idea of xenogeneic vaccines was based upon an observation made by a graduate student in our laboratory about 14 or 15 years ago. And she was trying to get mice to recognize a target found on mouse melanoma cells. And so she tried and tried and tried different ways to get mice to make antibodies and T cells against this target found on melanoma cells. And she couldn't do it. But one day, she injected mice with human melanoma cells. And lo and behold, the mouse made antibodies to this target on human melanoma cells that's also found on mouse melanoma cells. And in fact, we as humans are much more similar to mice than we think. In fact, for these proteins that we're looking at on melanoma cells, we are 85% identical to mice, which is a little bit scary when you think about it. But that 15% difference is just enough to get the immune system to think that this is something foreign and to respond to it. And so we found that immunizing mice with the human version of targets found on mouse cancer is a very potent way to get mice to reject mouse cancer. And so we then did the opposite experiment in humans. Next slide, please. And this just shows you the different types of vaccines that we looked at and how we settled on DNA vaccine, which is the gene that tells the body how to make a particular protein target that's found on the whole cell. The next slide. And so we did a trial that started here at MSKCC about, it was written about 11 years ago, but it actually started about 7 or 8 years ago, where we actually injected human melanoma patients after surgery with the gene for human tyrosinase, which again, remember that's the target that we identified based upon that self, and the gene for mouse tyrosinase. Again, so to turn the tables and use the mouse target in humans as a way to overcome the immune system's reluctance to recognize something that's self. And we did this trial in about 18 patients here at Sloan Kettering, and we finished it a few years ago. In the next slide. And we actually showed that about 40% of people made T cells that recognized human tyrosinase when they got the mouse tyrosinase gene. In addition, at the same time, we also did a clinical trial in dogs with melanoma. And turns out that dogs get mucosal melanoma very commonly. They get melanoma in the mouth. And in fact, melanoma is the most common tumor of the mouth in dogs. And so we reasoned that if we used either the human or the mouse gene as a vaccine in dogs, we could possibly get some decent results. And this was one of our first clinical trial participants there, that Siberian Husky, whose owners are shown there with him. Okay, the next slide, please. And this is just showing you a picture of dog melanoma. It grows as a a pigmented nodule in the mouth of dogs, and sometimes it can happen on the nail bed in dogs. Next slide. And this is actually a chest x-ray of that dog that I showed you in the slide 2 slides ago, with the arrows pointing to lung metastases in that dog, which came up about 2 months after the dog finished surgery and radiation therapy for a mouth melanoma. The dog was vaccinated in the year 2000, and within about 6-month period of time, both of those metastases went away. The dog ended up living about 2 more years to the age of 13.5 and died of an unrelated cause. And so we were obviously happy about this, but it was just one dog. And so in the next slide, we actually went on to immunize a lot more dogs. And again, these are people's pets. We're not giving these dogs melanoma. These are dogs that get melanoma for the same reason that people do, an interaction between their genes and their environment. And dogs are outbred large animals, just like people. So we think that they're a really great way to study new treatments for human melanoma. And what you can see on the left side are survival curves for dogs before the development of our genetic vaccine. And you can see dog melanoma staged the same way that human melanoma is, with, in this case, dog stage 3 melanoma, a lymph node metastasis, dogs living about 3 or 4 months at most. But you can see in the curve on the right, those dogs are living about 3 to 4 times longer. And in the next slide, you can see that actually our dog melanoma DNA vaccine actually was approved about 3 years ago, and it was actually the first approved therapeutic cancer vaccine in the United States. It's available for use in dogs only. We don't think that it'll have any, this particular one approved for dogs will have any activity in humans because it's made from the human DNA. It would need to be a mouse DNA vaccine to have activity in humans because obviously it would be the same species. But we're very proud that this is the first approved therapeutic cancer vaccine in the United States. Okay, the next slide. Now it's got a sexy name. It's called Oncept. Okay, the next slide. But these are clearly, there are clearly challenges in vaccine development. There have been no clinical trials in human melanoma yet that have shown a survival benefit like we showed in dogs. Maybe it's because dogs are smaller and we can get away with lower doses of the vaccine. Maybe dog immune systems work differently than humans. We don't really know yet. But we do know that there is a need for high potency in vaccines to overcome immune suppression that the tumor produces. Tumors have various different ways of self-defense. They make different substances called immunosuppressive cytokines or immune hormones that down-regulate the immune system. Tumors build fibrous walls around themselves or capsules to keep out immune cells. And tumors have things on their surface, proteins that cause T cells to die when they come too close. In addition, tumors can lose those HLA molecules from their surface that prevents them from showing things to the immune system. So we need to get a very, very potent immune response against cancer in order to really show a therapeutic effect. I think that the optimal population for cancer vaccine trials, for melanoma vaccine trials, is done post-surgery when the negative influence of the tumor is at its lowest point. However, this is a difficult endpoint for clinical trials because you have nothing to measure other than how long a person lives, and this can be an endpoint that can last many years. And so there's a reluctance on the part of industry and funding agencies to go into this type of setting where you're measuring overall survival, which can take 5 or 10 years, since it's so darn expensive and requires many, many patients to do. That's why vaccine trials are so difficult to do. In addition, the track record for vaccination in melanoma in particular has been rather spotty. And so since companies have to consider this, they have to consider what's likely to be a return on their investment, and funding agencies also have that to consider. The more negative trials we do, the less enthusiasm there's going to be. So we really need to think about what our next steps are in vaccine development and take a big, bold approach that really enhances potency. And that's why I think there's a bit of a lull right now in vaccination strategies while we try to tool up and learn from what's been done in the most recent clinical trials. And I'm going to tell you about that in a second. Next slide. So I'm going to tell you the story of a couple of different vaccines that were recently done and why they have taught us some important lessons. So one is a vaccine made from a ganglioside, which is a fatty sugar molecule found on melanoma cells and other cancers. And this was actually a vaccine developed at my institution by my partner, Phil Livingston. And it showed some very interesting activity in early clinical trials. Next slide. This just shows you the structure of the vaccine. The next slide. This was a trial that Phil Livingston did almost 20 years ago in stage 3 melanoma, where he compared BCG, which is a tuberculosis vaccine, alone with GM2, the melanoma sugar molecule, combined with BCG, and it really looked like patients who got the melanoma vaccine did better in terms of overall survival. And so based on that result, in the next slide, a bigger trial was done. There were trials done here in the United States by the ECOG group led by Dr. Kirkwood, and also in Europe. Here, this is in stage 2 melanoma led by the EORTC, which in this case compared the GM2 vaccine to observation alone in patients who had surgery for stage 2 melanoma. Okay, the next slide. This shows the disease-free survival. So this shows basically the time to recurrence, which was really not very different between the two arms. Okay, the next slide, please. This shows the distant metastasis-free survival, which shows a little bit of a disturbing trend that the observation group seemed to be free of distant metastasis for a little bit longer, but it wasn't quite statistically significant. And then the next slide. And this is the overall survival, which actually showed a significant difference with actually the vaccine group doing worse. And this was very troubling because this was a big trial, and this data was obtained when just a small number of the patients had finished, so the trial was actually stopped at a very early time point because of this observation. Now, this data was presented at ASCO 2.5 years ago, but a year and a half ago was represented, and this difference was no longer statistically significant. Actually, it was 3.5 years ago. But this was no longer statistically significant when it was reanalyzed. So again, I think that this is one of these things where if you've got a big trial which requires a long time, there is a desire to look early and see what's going on. But if you look too early, you may get a very negative answer that turns out not to be true. And this kind of puts a bit of a problematic mark on vaccine trials. Okay, the next slide, please. Okay, and so when this trial was looking like it was going in the wrong direction, meaning negative, Dr. Egermont, who was the presenter of this data, said, have we seen this before? And the answer was yes. When this same vaccine was compared against high-dose interferon, again, at an early time point, it looked like the vaccine was not doing as well as interferon. And then again, allogeneic cell-based vaccines, again, we talked about Canvaxin. There were 2 trials in stage 3 melanoma after surgery and in stage 4 melanoma after surgery, both with the vaccine group looking worse early on. And we have that data in the next slide. So this is the data from the ECOG trial, interferon versus the GM2 vaccine. Again, an early time point looking slightly worse. And then again, next slide. This was the Canvaxin trial. This was the design of the trial. Next slide. And again, you can see BCG, the tuberculosis vaccine, with placebo doing slightly better than the BCG with the melanoma vaccine here in the stage 4 melanoma trial. And then I think I have next the results in the stage 3 trial. Yep, here's the stage 3. And one more slide. And this shows, again, the BCG with placebo doing better. So, these trials require more follow-up. These were early time points. We need to know whether these vaccines could possibly make people worse. Now, why could vaccines make people worse? Well, again, with allogeneic vaccines, you may be immunizing against the wrong targets. And if you're distracting the immune system by causing them to respond to the wrong molecules, then maybe the immune system won't see important things on your own patient's melanoma cells. In addition, with the GM2 vaccine, it may be that immunity to GM2, when antibodies bind to GM2, maybe that makes melanoma cells grow faster. So that's why when patients come and say, well, I want a vaccine because there's no way that vaccines could possibly make me worse. Well, we don't know that that's 100% true anymore, and that's why we need to do clinical trials to find that out for sure, because we've all got very positive outlooks about vaccines based on how successful they've been for infectious diseases. For cancer, it's more tricky. We need to consider what the ramifications are of causing antibodies to bind to these targets on the melanoma cells. Could they cause the melanoma cells to somehow get signaled to grow more quickly? Don't know yet. We have a lot of work yet to do. The next slide. Okay, we're going to skip through that since we went through this already. Now, the last example of how vaccines are a bit problematic at the moment comes from the data from the Ipilimumab phase 3 study. And this was data that I went through on my last webinar. And again, remember, in this trial, there were 3 groups. One got Ipilimumab alone. One got a GP100 peptide vaccine. And this is, again, a small snippet of synthetic protein found on melanoma cells. And some patients got the vaccine alone, and some people got both, the Ipilimumab with the vaccine. And when the trial was designed, the thought was that combining the Ipilimumab, which releases the brakes on the immune system, with a vaccine would cause a really robust antibody and T-cell response to these targets on melanoma cells that would be able to control the tumor growth. And in the actual data, in the next slide, what you see, the blue and the green line, are exactly the same. One of them is the Ipilimumab alone. One of them is the Ipilimumab with the GP100 vaccine, and they're the same, and they're both better than the vaccine. Now, it wasn't a big surprise that the two Ipilimumab-containing arms were better than the vaccine alone. But it was a little surprising that the vaccine plus Ipilimumab did not do better than Ipi alone. In fact, if you look in the next slide, at the, I think that, is there one more slide? Yes. In this slide, if you look at the best overall response rate, the BORR numbers, that's the number of patients who had tumors that actually shrank by at least 50%. The Ipilimumab alone group did about twice as well as the Ipilimumab plus GP100 group. So the addition of the vaccine actually decreased the number of patients who had a significant reduction in their tumor volume. Now, that did not translate into a difference in overall survival because, again, Ipilimumab is able to cause reactivity to a broad array of different targets. And I think what happened eventually is those patients who had the vaccine at the beginning may have had a very strong response to GP100, but that may be not enough to cause melanoma to go away. eventually their immune systems had to be educated to see different targets, and we know that Ipilimumab can do that, and their survival, therefore, was unchanged. So again, right now, the timing of vaccines with immune modulators like Ipilimumab needs to be better worked out. It doesn't seem to be the right answer to give it along with an immune modulator like Ipilimumab, or maybe this particular vaccine just wasn't the right target. Again, a small snippet of one protein, or in this case was two small snippets of one protein, maybe that just wasn't enough. We need more robust targets. Again, a lot of thinking to do and a lot of opportunity now that we have Ipilimumab, anti-PD-1, anti-PD-1 ligand, and other immune modulators to combine with vaccinations. Next slide. Whoop. Wait a minute. My screen just went dead. Okay, so explanations and paths forward. So explanations for why we have not had a smashing success with vaccines against melanoma. Early data analyses sometimes, I think, lead us to premature conclusions and premature negativity about this. And we need to break that cycle of negativity. And maybe the approval of Sipuleucel-T or Provenge for prostate cancer will break that negativity about cancer vaccines. We need to enhance potency. We may be targeting the wrong antigens, and we may be inducing suppressive T cells. How do we get around that? Well, we may recognize that perhaps the best vaccines against cancer are the tumor cells that are inside the patient. And the best way to get the immune system to see those tumor cells is by killing them while they're still inside the patient. How do you do that? With chemotherapy, by radiation therapy, by targeted therapy like RAF inhibitors, causing that debris to be released, and then maybe giving a drug like Ipilimumab that gets the immune system to attach itself to that debris, so-called endogenous vaccination versus exogenous vaccination where we stick in the vaccine with a needle. Now, it would be great if we could identify mutational antigens, if we could find a vaccine target in BRAF, because that's unique to the cancer, and, of course, combining with immunomodulators. Like Ipilimumab and anti-PD-1 in the right schedule. So that's really most of what I wanted to say. I'd like to thank you for your attention, and I think we have time for some questions.
Wonderful. Thank you, Jedd, so much. You know, patients always say they wish they were mice. And,
right.
And now I'm
or
thinking,
dogs.
Yes, and now I'm thinking, well, maybe dogs too. Although we're closer to mice than I thought. I never knew that.
I usually will follow up that comment by saying that some people are closer to mice than others, but.
All right. I have just a few questions here, and some of the things you have sort of gone over, but I don't think it would hurt to repeat some of the things that you've been through. First question is actually mine, and I wanted to know what you felt were the most exciting vaccine therapies now available in clinical trials today. I know the Oncovax has had mixed results, and that's something ongoing right now. Is there anything else we can look forward to that's currently available?
I think currently available, it almost varies institution to institution. The largest vaccine trial in melanoma right now is being run by GlaxoSmithKline, and it's a recombinant protein for a target called MAGE3.
Right.
It's being explored in both melanoma and in lung cancer. And I think that that's a very important trial. And goodness knows if that trial is positive, I think that will be a real jumpstart to the field. And I think that's an important trial because it uses a very powerful immune adjuvant, which is, again, a group of chemicals that try to make this protein interesting to the immune system. You know, Glaxo really did their homework on that trial. They did a bunch of preliminary studies and came up with, you know, a very potent way to try to immunize. And I think that that's an important study to consider if someone has access to it. Other trials that are going on in different places, people are still looking at different peptide vaccines around the country. I think that my most enthusiastic recommendation would be to look for a vaccine trial that uses a new adjuvant, a new something that the vaccine is mixed with to make it interesting to the immune system, whether it be something like Ipilimumab or anti-PD-1. There are other things, something called poly-ICLC, which is it looks like a component of a virus that the vaccine is mixed with to make it more interesting to the immune system. But there are a lot of novel approaches out there. Not many of them in wide use in terms of multi-center trials, because again, I think the field is trying to learn from where it's been and doing a bunch of smaller studies right now to try and figure out what the next great leap forward is.
Right, with the MAGE-3, you have to be MAGE-3 positive, correct?
The tumor has to be MAGE-3 positive, right. So, and that makes sense because you wouldn't want to vaccinate someone whose tumor didn't have that target. And it is the majority of people who do have that target.
Oh, okay. And that's for stage 3 disease as well?
Yes, correct. 3.
Which we're real short on, so that is a great one. And the Oncovax, do you have any?
Well, Oncovax is really not a vaccine, so to speak. It's basically a virus that gets injected into a melanoma cell, and it tries to turn the melanoma tumor itself into a vaccine. So it infects the tumor, and it produces an immune hormone in the tumor and tries to turn that into a vaccine. So I think it's a really interesting idea. There have been some very intriguing early results from their smaller studies, because what they're hoping to show is that they inject a tumor in one part of the body with this, viral construct, and then that causes the immune system to mediate regression of tumors in other parts of the body. And that's really the dream. That's what we're hoping to do. But I don't know if we know that yet. We're hoping to learn that from this trial that they're embarked on.
Okay. This is a broad question, but what side effects can you expect to have when you're doing a vaccine trial? Is there any kind of general?
Well, the general thing is, if it's not a virus, then you'll probably get a sore arm or leg or wherever they injected, and a little bit of redness at the injection site. And you can get, some low-grade fevers and headaches, and feel a little bit crummy for a day or two. That's sort of the general description. But some of these vaccines, like some of these viral vaccines, potentially if it's a live virus that you're being injected with, you could actually get a low-grade viral infection. And in addition, again, you're trying to cause reactivity to self. So if you've got a target in the vaccine that's also found on normal melanocytes, then you could develop vitiligo, and you could develop inflammation in the eye.
Okay. At what stage of melanoma can you expect the best response when giving a vaccine therapy?
Excellent question. I think that the earlier, the better. But again, with very early stage disease, there's a reluctance to expose patients who are likely cured, to an experimental product with unknown side effects. So I think that's why the sort of deeper stage 2 and stage 3 patients have been, in my mind, the ideal population for vaccine studies, because they have all their, gross disease, their measurable disease has been removed. And so the immunosuppressive influence of the tumor has been minimized. Yet they do have some risk of recurrence, and ethically you can feel okay about the possibility of giving this group of patients the opportunity to participate in a study using an agent that you might not know all the safety data for yet.
But isn't the issue with stage 2 and 3 that it's really hard to measure responses
Well, what you're measuring in those people is overall survival. That's the challenge. Is that
Right.
and with the understanding that there's a significant number of those people that are going to be cured just by surgery alone.
Yeah.
And so that's why these trials need to have a lot of people in them, and they need to be randomized, and they need to be followed for a long time. So that's why this question is a challenge, because to get to get someone to pay for these huge trials that take a long period of time is very difficult.
Right. That's why we have so very few stage 3
Yep,
trials.
exactly right.
Right. Now, so do you normally have to be HLA positive for a vaccine?
No, only for certain peptide vaccines.
Okay, so are there going to be other tissue types that are going to be?
Yes, absolutely. We're learning more and more about that as we go on. I think there are fewer and fewer trials now that are HLA-A2 restricted.
Okay. And do you think there'll be a preventative vaccine for melanoma, like for? Is that one for dogs? Is that preventative, or is that a treatment?
No, it's therapeutic.
That's therapeutic.
Yeah.
But do you think there could ever be a...
Goodness, I hope so. I mean, I think if we could find a good immunologic way to target mutated BRAF, wouldn't that be a wonderful thing to vaccinate against? Only found in nevi and melanomas, and unique to the the genetic lesion that causes the disease. So I mean, I think if we found an effective and safe vaccine, then the dream would be to move it into the preventative setting. But I think we're still quite a ways from that.
Yeah. Now with mucosal, acral, ocular, the types that we really, I believe, would say are more genetically caused than environmentally. That's my thought on it. I don't know if you'd agree, but we tend not to know what causes mucosal, acral, and ocular as well as we do.
Well, it's some interaction between genes and environments, right? So the acral melanomas, about a third of them will have the c-KIT mutation, and so will the mucosal. So there's some genetic change there, and it's not a heritable genetic change. So it was caused by some some environmental influence. We have no idea what it is. You're absolutely right. Now we, at least here, have kept our vaccine trials open to folks with ocular, mucosal, acral melanoma because the targets that we've used have been pretty uniformly expressed by all those different melanoma subtypes.
Would these disease groups be, a better one to target with a vaccine because they're not like cutaneous where we know the environmental?
I don't think they're any better or any worse. Would be my take on that.
I was just thinking about the dog has mucosal, correct?
The dog has mostly mucosal. You're right.
Okay. So I just wondered if there'd be a correlation there.
I don't know.
Okay. And then finally, something you touched on that is the question that I have is combining these vaccines with Ipi or the BRAF or the MAC as feasible combinations. And so you do think there is some promise of that?
I think that, I think combinations are where we need to be. But we need to really do our homework in terms of how to combine them in terms of sequence. Timing is very, very important. So I think that's where we're going to be, is combinations of immunotherapy and targeted therapy or chemotherapy. That's really what the future holds. The two paradigms that I like to talk about are treating the patient and treating the tumor. And we treat the tumor with these new targeted therapies that so selectively impair the tumor's driving genetic pathways. But we know that that will certainly cause tumors to regress for a certain period of time. But we also need to mobilize the immune system of the whole patient to try to take the opportunity to recognize dead melanoma cells during the time that this is all going on, so that the immune system can continue to hold things from recurring, even after, say, BRAF inhibitors aren't working anymore. So I think that the world is quickly coming to the conclusion that combination therapy, treating the patient and treating the tumor, is where we need to be. And I think there are important trials that are going to be starting very, very soon that take this into consideration.
Great. Well, I really thank you again for coming and explaining to us all of these complex things in a way that we can understand them. And you always give me so much hope, because I really do hope that there's this combination. You just hand this to all the scientists out there, and they're going to find it, one way or the other, and we can finally say we've gotten somewhere with this disease. So
I'm 100% behind you.
Right. Thanks again, Jedd.
Okay,
really
thank you for having me. Okay, have a good evening, everyone.
You too.
Bye-bye.
Bye-bye.